SDM say would be to take over the session. Welcome, sir.
Okay. Now instead of going to the issue of your neoplastic lesions, I think we have to complete whatever we have done in the previous sessions. The previous session we had discussed about SLE, so we'll try to finish up that part and then we'll go into the next issues.
Yes.
Point where we have left out in the previous session was about the clinical diagnosis of SLE, and because SLE presents with various forms of clinical presentation, the radiological signs produced due to SLE also are quite wide variant. So there is no single issue or a single entity by which we can make the diagnosis
Sir,
of SLE. The
sir,
uh,
sir, screen is not visible, sir. Sorry.
screen is not visible. Is it visible now?
Yes, sir. Yes, sir.
Now, the radiological signs are of different categories, which could be, it's not a single issue to make the diagnosis of SLE, and it could be like periarticular bone demineralization or soft tissue swelling around the bones, joint, or polyarthritis, which involves the hands, wrists, etc., or joints spaces which are reduced joint spaces, which can even result in fibrosis, or a deforming but non-erosive arthropathy, which is also called as Jacob's arthropathy, or erosive arthropathy, where there could be occasional erosion also, or it could be like the sclerosis or the hardening of the bone at the epiphyseal end of the bone, or that's acral sclerosis, or even osteonecrosis, necrosis of the bones like femoral head also can occur, or even many times avascular changes also can occur in the joint. Often these changes also could occur as a result of the steroid therapy, or there could be fractures produced due to osteoporosis. Osteoporosis induced the fractures, which is also called as osteopenic fracture, or there could be infections of the joint due to again steroid administration or renal pathology, or myositis where the muscles could become hardened and the muscles may even have the calcification, or there could be spine manifestations like subluxation. Now I will show you some of the examples of these issues as we see many times, like the periarticular bone demineralization, where you will see the density of the bones being lesser around the joint spaces. This is one of the most common presentation in case of the SLE radiological findings. Many times the patients would have vague clinical symptoms like pain in the joints, which mimics rheumatoid arthritis, but RA test would be negative, and when you go for the X-ray, you will find this demineralization, which could be the evidence of SLE. Then we will have to go for SLE workout that makes the diagnosis. So from the clinical point of view, this is one of the important issue, and this kind of patients do come quite frequently. Then the periarticular soft tissue swelling, which you see, the example would be, which you can see over here in the X-ray, where the around the joint space that soft tissue swelling is visible, and the joint space otherwise may look normal, or maybe there could be some effusion. And this soft tissue swelling is better made out with the ultrasonography, where there could be the inflammation and the fluid collected around the joint space, which is easily visible with the ultrasonography. Or CT also can show you the same changes. The demineralization of the joint spaces also can be better measured in the CT, but practically most of the times we make the depend upon the diagnosis of either the plain X-rays or occasionally ultrasonography. Then Jacob's arthropathy is another of the typical presentation where the joint would have a deformity, but unlike that of rheumatoid arthritis where there would be a swan neck like deformity, here in this case the terminal the phalangeal joint would be flexed, whereas the middle joint tends to be extended as such, and there would be a significant deformity. Gap between the two phalanges tend to increase towards the lateral side, whereas the middle two fingers, the joint, the space becomes lesser, and this kind of a phenomena is also almost characteristic of that. Of course, in case of SLE, there can be even avascular changes, avascular necrosis of the bones also. As you see over here, the hemate bone has some necrotic changes, which also could be the features of SLE. Or there could be erosion of the joint, that erosive arthropathy, where the joints may become erosed, the erosion of the bone around the joints, and the surface becomes rough. Now, as you see at the terminal phalangeal spaces, as a result of that erosion, the terminal phalanges may become just curved, and the radiological findings may be having that features of the erosion. The density becomes more, fibrosis will be more, and the axis of the joint tends to become altered. Joint space also may become reduced. That also is a feature of the SLE. Or there could be the sclerosis, the acral sclerosis. At the epiphyseal end, there could be sclerosis, and virtually the bone in the X-ray may become less visible. The whole calcium bone calcification content could be reduced as such, and that could be the feature. And hence, in that condition, the visible signs, like when you look at the hand, the fingers tend to be looking like there could be the terminal part of the fingers, they are maybe swollen, or the size may be reduced, like, and the patient would have severe pain at the terminal area, terminal phalanges. The terminal phalangeal bone would be almost eroded, like at this point. That is the typical feature of SLE occasionally. Or there could be the fractures, insufficiency fractures. There is the osteoporosis induced fractures, as you see in case of this femur neck. At the neck area, neck of the femur area, there is a loss of bone tissue, and there is a fracture. And many times in this or in the it could also could be in case of the vertebral bodies or any of the bones, as a CT image of the vertebral bodies, where you have the erosion of the bone and then there is a fracture line in the vertebral body, or so on. So the features could be of this nature, where the amount of the trauma producing the fracture would be minimum, and but the changes could be quite significant. So secondary trauma of the fractures, like where there could be the primary pathology of the erosion, and that also can be a presence of features of SLE. Cerebral infarcts produced due to SLE also are quite characteristic. Unlike that of the other infarcts, where the density of the infarct area can be uniform, in SLE-induced infarcts, the density of the peripheral area of the infarct would be quite more, and the central area there could be some necrosis. And if you do go for the angiography, in case of other vascular obstructions due to the clot, there could be a sudden obstruction of the vessel, whereas SLE-induced obstruction, the vessels become narrowed gradually. You can see this artery becoming narrowed, and still to a certain extent the dye flows through the artery, then you have the infarcted area. Similarly, as you see over here, so a vascular obstruction produced due to a embolus and a vascular obstruction produced due to SLE, they are slightly different as such. From the management point of view, in case of SLE-induced conditions, glucocorticoids are absolutely necessary, and they can produce a huge change in the clear clinical outcome, whereas in a vascular obstruction, the steroids have only minimal indications. So that's all important issue, making the diagnosis of SLE. The basic issue is diagnosis of SLE itself is a very difficult issue, but at the same time, it's not enough if you make the diagnosis of SLE. It's also important, like whether the SLE is involving multiple organs or not. Predict the prognosis or the changes they are produced due to the SLE have to be assessed. and this is done by a typical or standard protocol called as a assessment of the damage index or irreversible organ dysfunction index. And for this, if you look at the literature, you have many options like SLAM, that's systemic lupus activity measure, or SLEDA or lupus activity index, LAI. Lots of them are there. Literature would be producing lot of confusion, but I will just suggest about one of the standard features which are followed by majority of the people and comparatively easy to make out the indexation of the disease activity, which I do usually follow in my clinical practice to a certain extent. The other prognosis can also be depending upon the clinical evidences. Clinical evidences like skin lesions, arthritis, or neurological manifestations as seizures or psychosis, kidney involvement. These are the major, most important clinical signs which could be leading you to the suspicion of the SLE. At the same time, the diagnostic study results of anemia, thrombocytopenia, leukopenia, or serum creatinine levels also should lead you to suspect about the SLE. Then if you go for immunological tests, the C3, C4 concentration, which we usually generally do not do in the regular study, but if you go for the specific study, that immunological test would be sufficient. Or anti-nuclear antibodies, ANA, also could be of use in making the diagnosis of SLE. From the clinical point of view, that SLE disease activity index, SLEDAI, is more convenient, easy to make out than the other parameters. I have referred to many of those methods by which you can assess the disease index as well as the disease activity index. Whereas SLEDAI, which is more commonly used by majority of the research papers, use this method, and I would consider this as one of the important issue to measure the disease activity. And when we plan the management, like from early management of SLE, this disease index activity is a quite important issue by which you can predict the prognosis to a certain extent and whether it's manageable or not. Even that would be the important issue. Suppose the patient has seizures, then the score would be 8 as such. We will have a relatively high scores for the symptoms of seizures, or patients who have psychosis symptoms, or there is a organic brain, the brain damage as in case of the vascular pathologies, or if the patient has a visual disturbance, or if the patient has a clinical nerve disorders like any of cranial nerve disorders like this bulbar palsy, etc., or the patient has a lupus headache, severe headache, or the patient has cerebrovascular accident symptoms, presentation with the typical feature, then in all that neurological conditions the score is quite high, which is 8. Then if the patient has symptoms of vasculitis where the peripheral vessels are involved, then again the score is high. Symptoms of arthritis, myositis, the skeletal structures, or urinary symptoms, or patient having hematuria, or the patient who has proteinuria, or the patients who have pyuria, the urinary symptoms and the skeletal symptoms, the score would be 4 plus. And if the patient has the symptoms of the rashes, alopecia, or the skin features, mucosal ulcers, or there could be in that condition the scores would be added to this. These scores are calculated based upon the statistical incidence of the disease outcome, and hence that the score would be comparatively lesser. The symptoms of pulmonary involvement or cardiac involvement, that pericarditis or pleurisy, are in that condition the score would be again comparatively low 2 as such, because now this score is about the statistical incidence of the diseases symptoms occurring in the patients as such. If the patient's biochemical tests like the complement study CD is that C3 C4 study shows a lower level, then the score will be 2. Whereas if it is ANA is increased DNA binding, that's the anti-nuclear antibody studies, then the score will be 2. Symptoms of fever, thrombocytopenia, leukopenia, the score will be still lower, like one as such. Then these are what we call as reversible symptoms, which may be present at the time of your examination but may not be presented as the other way. If the symptoms are persisting for a long time and they are not reversible, cannot be responding to the treatment. So most of the patients who come to us, they are of this category, where we may have to add two more scores to this irreversibility, like ocular symptoms or neuropsychiatric symptoms, ocular symptoms like cataract, we will add two more. Neuropsychiatric symptoms which are irreversible, you add 6. So patients who have a primary neurological symptom, the score will be 8. And if the patient has already tried many other treatment and then they come to us, then the score will be another 4, that is another 6, let's say 14 scores would be there. That makes it quite high as such. If the patient has a glomerular filtration rate of lesser, like renal pathology is quite prominent, then and that's irreversible, then you add some more scores like 3 more. Pulmonary hypertension which is not responding to the usual treatment, then there will be additional 5 scores. If the patient has a cardiovascular myocardial infarction as such, then the patient would have, you will have to add 6 more scores. Or peripheral vascular activity like venous thrombosis, then again another 5 score. Or if the patient has gastrointestinal pathology like history of bowel resection, which is comparatively less common, or patient has a gallstones or biliary pathology as such, then you will add another 6 score. If the patient has a osteoporosis and fracture, then again another 6 score. Skin where the patient has a scarring as such, then another 2 scores. Having other diseases like gonadal failure, like infertility or diabetes or malignancy, you will have to add some more scores as such. So based upon this, if the total score is more than 40, then the prognosis is poor. If the total score is less than 40, we can manage to a certain extent, and this is how it is categorized. And the conditions are categorized into mild, moderate and severe. Mild is when the score is in between less than 40. A 40 to 80 score is moderate, above 80 score is considered as a severe. Now, in the current pharmacological management, the standard Euler recommendation of the management of SLE would be depending upon the scores as such. From our clinical point of view, how I manage, I will come to that part later. So this is a universal guideline, the Euler guideline, European Union guideline against rheumatism. The important issues are, in all the patients of SLE, the most important part would be according to the contemporary science, the Euler guideline, the skin protection, taking care of the skin hygiene, exercise, no smoking, balanced diet, vaccinations because the patient has a reduced immunity, these vaccinations, maintenance of the body weight, maintenance of the blood pressure, lipid and glucose control. These are the one. And then another common prescription is acetylsalicylic acid. That's the aspirin, ecospirin is one of the common prescriptions as such in all cases of SLE. Then if the patient is in a mild category, then HCQ, that's hydroxychloroquine, is the usual prescription. If the patient is mild but not responding to the usual treatment, then either methotrexate or azathioprine or even mycophenolate is added. If the patient is in moderate severe the category as such, then the disease modifying drugs like belimumab or anifrolumab, they are added. And if the patient is in the severe category, cyclophosphamide or rituximab, these are the usual treatment is suggested as such. And steroids, glucocorticoids are usually prescribed in all such conditions at relatively higher doses. This is the usual prescription and the mode of prescribing the drugs according to the Euler guideline. Now, the outcome of this treatment is considered to be improving, like as per the data, statistical data available. Prior to 1955, 5-year survival rate of SLE was less than 50%. Currently, the average 10-year survival rate exceeds 90%, and the 15-year survival rate is around 80%. Now, 10-year survival rates in Asia and Africa are significantly lower than the United States, ranging from 60 to 70%. Now, I am suggesting this data because with our average management, if we can achieve this result, then we can say that our treatment is equal good. And as per my experience, I think our results are almost at the same level, or maybe slightly higher than, better than these results. Survival result of patients are more than 80% in majority of the patients whom I have treated, and majority of the patients who come to us are those who have failed with or who have not responded properly or who are not happy with the current treatment given earlier. So from that point of view, this is an important issue. Though I may not have a very objective this assessment of the survival period and the duration, but my guess is, as per my patient follow-up condition, I think our results are almost equal or maybe slightly better than this 70% or 80% the issue. The most of the, and another important fact is again from the same reference. Previously, mortality was due to the disease itself, but currently the mortality often is a result of medication adverse effects like fatal infections and individuals receiving potent immunosuppressive medications or cardiovascular disease events. A very important issue. This sentence, I have not modified any sentence word in that sentence. It's exactly copied from the same article, that reference article. You can see the reference article, which suggests about the present status. And now, when it comes to a question of advantages of Ayurvedic management and so on, this also is an important issue. From Ayurvedic management point of view, this issue, like complications of the medications, would be of not much significant. In general, when we manage the general idea, even if you do not go into that standard disease activity assessment, still the general management would be, if the patient has cutaneous manifestations or musculoskeletal manifestations and maybe slight serositis, then they suggest about milder disease, which may have a course where there could be slight increase or reduction of the activity. And as per the standard protocol, they could be managed with the non-steroidal anti-inflammatory drugs, NSAIDs, or low potency immunosuppressive medications like hydroxychloroquine as per the current situation, or maybe the steroids. From our Ayurvedic management point of view, these are the conditions which we can manage comparatively easily with the similar treatment, the line of treatment of Mamsavaha. I will come to that part later. Then the more prolonged steroid use is generally reserved for patients with involvement of vital organs like renal involvement or central nervous system involvement, or patients who have more severe manifestations. From our clinical point of view, if the patient has a mild like cutaneous manifestation, I would be considering this as the Kushta variety, the varieties of Kushta, either Kapala Kushta or maybe the complications of the Kshatraja Vranas, like where Krishna Aruna Kapala Medruksham Proshantanu Kapalam Tadabholo. Kapala Kushta could be the diagnosis in the skin manifestations of the SLE. And I treat the patients with the Kaisharukul Arogya Manjistavipata or Virechana as the other option, and the patients usually respond very well. Many of the patients who are otherwise resistant to the other contemporary treatment, or even who have failed with the glucocorticoid treatment, they do recover with our medicines. Patients present with the musculoskeletal manifestations, I would consider them as the Amavata, the typical features of the same, particularly Bahuama, where there could be severe ama. The clinical features like Guru Angam Tuddire Atyartam Dandam Mustihatam Tatha Saruk Shamitam Atyartam Mamsamedogata Anile. Mamsamedogata Anila also, Vata also would be presenting with the similar features, and in these conditions, my treatment would be Kaisharugulu Mrityunjaya Amatarishta, Agni Chikitsa and Ksharabasti. If the patients are on glucocorticoids, majority of the patients who are on glucocorticoids or other immunomodifying drugs like methotrexate or etc., they can be stopped gradually and even withdrawn completely based if the patients are on regular follow-up. Whereas if the patient has a renal or cardiac involvement, the prognosis is poor, And I would not just manage the patients only with ayurvedic management. I will be advising the patient to continue the contemporary treatment. Along with that, I will be prescribing Chandraprabha, Punarnamandura or Prabhakaravati as the case may be, or as the patient in a CBA symptoms, the usual protocol of the treatment of Pakshagata, along with whatever the treatment is being continued. So I will not stop that, but the prognosis is poor. So if you have that kind of a discretion and assess the conditions, definitely the results can be much better than the standard results which are observed. So that's about the SLE and its treatment protocol as such. Now some more of those conditions, autoimmune conditions, are the connective tissue disorder pathologies. Systemic sclerosis is one more, scleroderma. And of course, from the clinical point of view, the number of patients whom we see with the scleroderma are comparatively lesser, but the most important is this is one of the important diagnoses which makes some confusion overlapping with the SLE. Many of the patients of systemic sclerosis, they may be diagnosed as SLE and the vice versa. The only difference is in the scleroderma, involvement of the kidneys and the other organs are comparatively less common, and the clinical tests like the biochemical tests like ANA may not be positive in case of systemic sclerosis. Now, the definition of, or maybe the definite features of the systemic sclerosis is it presents with the initially vasomotor disturbances like giddiness or abnormality of the blood flow to the periphery, then presents with fibrosis, atrophy of the skin or subcutaneous tissue, or there could be rarely involvement of the internal organs like lungs, heart, kidney, and immunological disturbances also may be presented as such. The whole pathology of this scleroderma is considered as a result of chronic inflammation. So usually those patients who have a genetic predisposition, they tend to develop these scleroderma changes, and it's not a single event which occurs. It can result in a progressive pathology, and those who have genetic predisposition, they tend to have this condition quite commonly. It's a gradual process. The onset is always not predictable. It starts with some factors, the external factors which trigger these conditions, which involves the endothelial cells. The blood vessels will be altered, and then that results in chronic inflammation, and as a result of the chronic inflammation, the endothelial cells would be damaged, fibroblasts would be increased in almost every tissue, and hence if you look at the tissue study, gradually the tissue modification, the structure of the tissue is altered with this deposition of the fibrous tissues. So histopathology can confirm, though we may not do these kinds of investigations routinely. The clinical presentations are, the most important presentations are the skin sclerosis. The skin becomes stretched out and it looks like shining surface, mostly in those areas where the skin has to be more flexible, like arms, face, or in the neck. Then even there could be erosions or at the fingertip, or there could be lung fibrosis. These are the most important, and the cutaneous manifestations, skin manifestations may be presented in any of the three stages like edematous stage or indudative or atrophic. Majority of the patients whom we see, they would be present in the atrophic stage where the skin becomes atrophic. The patient would have that typical rigidity of the skin. Appearance of the skin is quite characteristic. So scleroderma clinical diagnosis is relatively simpler when the patient has a presentation of the skin. In addition to these other clinical presentations which can occur due to the scleroderma could be Raynaud's phenomena, where there could be peripheral vascular pathologies, dysphagia, breathlessness, or joint pain, and a majority of the patients would also complain of weakness, vague weakness, which are seen in 80% of the patients. The skin manifestations of the scleroderma could be of any of these categories. I think you can make out, and you might have seen many of the patients with this kind of manifestation which could occur anywhere in the face. It's seen as the rigid skin which can make the patient's expression quite odd. Particularly the eyelids, they tend to remain open, or the patient feels like or it looks like the patient is keeping the eyelids open intentionally. The changes also could be seen in the phalangeal area where the fingers may become flexed and the flexion of the fingers may become affected. There could be edema around the skin, the edematous changes of the skin also could be seen, or there could be gross atrophy as you see over here. As a result of the atrophy, the skin becomes constricted. Mostly it's in those areas where the joint is more flexible, sclerosis changes are seen. Or in the later stages, even it can result in telangiectasia. The skin becomes the blood vessels below the skin they become congested, and there could be multiple reddish spots seen around the area. Or even Reynolds phenomena, ischemic changes also could occur in case of the scleroderma conditions. Investigations which help in making the diagnosis of the scleroderma are either ESR being raised, thrombocytopenia, or gamma globulin would be increased. If you go for the gamma globulin study, IG studies, there it may show as such. Or hemolytic anemia also may be presented. Increased creatine CPK levels. CPK levels in patients who have involvement of the muscles, creatine phosphokinase or CKNAT now, which we do. Or increased urea and creatine levels in patients with kidney involvement. CRP would also be quite high. Confirmation is usually by the histological studies. Most of the times we may not go for the histological studies in our routine condition, but that could be one of the standard method of diagnosis. Treatment protocol comes from the contemporary point of view. As a symptomatic treatment for itching and rashes over the skin changes. The symptom usual treatment like application, local application of either camphor, menthol or cerulean, etc. Or the internal administration of corticosteroids, chlorambucil or mycophenolate, cyclosporin or tacrolimus, thalidomide, these also are used often. Statins are very commonly prescribed. From our point of view, I would be managing the patients with Kaishurugugulu, LSVT and Khadirarista or Manjustalic Vata depending upon the presentation, and the patient can be better managed rather with our drugs. A condition, a condition which resembles that of the SLE is also the polymyositis or dermatomyositis. Dermatomyositis, the exact cause is not known and it's characterized by symmetrical muscle weakness and the skin changes. So, and the typical electromyography changes where the muscle may be having that reduced activity, and it's immune mediated syndrome, and of course the incidence of these conditions are less frequent. We rarely see these patients. I have seen only a few of the patients in our routine clinical practice, and it can occur as a result of viral infections, malignancies or connective tissue disorders. Particularly the scleroderma and polymyositis, they are almost overlapping, and from the theory point of view they are again categorized into primary polymyositis or primary idiopathic dermatomyositis or polymyositis or dermatomyositis with the malignancy, childhood polymyositis or dermatomyositis as a childhood condition, or the polymyositis dermatomyositis associated with other connective disorders, or miscellaneous where we do not see such the causes. Of course, many of the patients whom we see are of the complication of either malignancy or the patients who have the connective tissue disorders like rheumatoid pathology or as such. The typical clinical presentation will be symmetrical proximal muscle weakness. The thicker muscles, bigger muscles are involved first, muscles become weaker with the gradual progressive onset, insidious onset as such. Pain is not a predominant symptom in the condition. Myalgia occurs only in 30% of the patients. Patients who present with the muscle weakness and skin changes but not much of a pain, the diagnosis could be dermatomyositis. Dysphagia and aspiration as a result of that also is another clinical presentation. Pain in the joints also may be associated, and the typical presentation of the muscle weakness would be like patient would have a difficulty in kneeling or bending forward, or climbing or descending the stairs, or stepping on some height as such, or raising the arm, lifting the objects, combing the hair, etc. That would be the typical clinical presentation where the proximal muscle weakness could be presented. Weak neck extensors may even result in the head position where the patient may hold the head up as such, which also could be the presentation of dermatomyositis. Then pelvic girdle may even present with the upper body weakness clinical symptoms. Rarely there could be cardiac involvement presenting with the pericarditis or cardiomyopathy, or face rash on face, trunk and hands also could be seen. The usual other dermatomyositis skin disease may presentation will be like initial photosensitivity, particularly eruptions which occur over the exposed part of the body, or pruritus skin lesions which may even disturb the sleep as such. Many times they are diagnosed as skin simply allergic manifestations, but they are not really allergic. There could be involvement of the skin muscles as skin as such, subcutaneous tissue. Erythema of the face or eruption along the eyelid margins with periorbital or without edema, and the eruption on the hands, mainly over the knuckles, or changes in the nail folds of the fingers, eruptions of the upper outer thighs, or scaly scalp or diffuse hair loss could be the clinical symptoms as such. And when that skin manifestation presented with the muscle weakness, the diagnosis could be dermatomyositis. Systemic manifestations, though are rare, they may be presented with the fever, arthralgia, malaise, or Raynaud's phenomena. Dysphagia also can occur. GERD symptoms could occur. Dysphonia of the patient's voice may be affected. Atrioventricular defects or tachyarrhythmias also could occur, or there could be the GIT disorders like ulcers or infections may be seen. Pulmonary involvement due to weak thoracic muscles also can occur. Subcutaneous calcifications may result in and with the contracture of the joints, which may be more common in children. Children may also have a changes in the gait due to the muscle weakness. Malignancy in adult patients. The polymyositis symptoms or dermatomyositis symptoms could be quite wide varying. Some of those typical manifestations are like periorbital that erythema, which may be seen as erythema spots, or the erythematous changes in the chest area, and the typical proximal muscle atrophy. The patient would have that kind of the phenomena. These are the typical features which we see. Investigations which help to make the diagnosis are the most important is a creatine kinase or CKNAC. You might have seen many of the patients where we do that CKNAC investigation, and it's moderately raised. It's not raised very heavy. The level could be something around 200 to 400, the CKNAC level. Then we suspect about a possible damage to the muscles due to the dermatomyositis. If it is very high, like 500, 600, etc., then there could be a significant damage to the muscles, necrosis of the muscles, which could occur due to the other conditions. Rarely there could be specific antibodies, particularly ANA level. Antinuclear antibody levels would be raised in dermatomyositis, and pulmonary functions. These are the other investigations can help in assessment of the patient's condition, like to confirm like whether the lungs are having proper ventilation or not. ECG or esophageal manometry to study the gastrointestinal functions. Colonoscopy to screen the underlying malignancy, or in women the malignancy screening with the tumor markers, or maybe Papa-Nicolau smear would be done. The most common complications which occur due to the dermatomyositis are interstitial lung disorders, aspiration pneumonia, heart block, arrhythmias, congestive cardiac failure, pericarditis, dysphagia, malabsorption, pneumonia, infections, and carcinoma, even steroid myopathy if the patients are on steroid therapy. The issue is these complications are common both with the sclerosis, dermatomyositis, as well as the scleroderma, and the treatment protocol would be almost same in all these conditions, like corticosteroids or immunosuppressive agents, or intravenous immunoglobulins, or antimalarial agents like hydroxychloroquine are often used. Our management, I have treated a good number of patients of these or both dermatomyositis, though number is lesser, whereas the scleroderma quite frequent. The treatment would be Kaishora Arogyavardhini or Lamsur Shekaravati, Manjistaliquata, then Anganjik and Ksharabasti, Virechana in chronic conditions. With this, we can produce a significant change in the outcome of a clinical condition. The next part, another common diagnosis which we usually write is a reactive arthritis, which I will deal with in the next session, and then we will go into the next part of our discussion. With this, let me conclude. If there are any questions, right? So we will conclude today.